My name is Laura, and my group members are Melissa, Shannon, Kyle, Ariel, and Emily. Today we will be discussing how limited ankle dorsiflexion is a risk factor for Achilles tendinopathy. Achilles tendon ruptures are the most common tendon injury within the lower extremity. This is one of the largest tendons located in the posterior leg, forming from the two major muscles in the gastrocnemius and soleus, which insert into the calcaneus. With each step taken, it carries our entire body weight, which can affect inactive individuals, however commonly impacts athletes who may play competitive or for leisure. So the question proposed within this case is, do active men with limited ankle dorsiflexion compared to those without limited ankle dorsiflexion have a risk factor for Achilles tendinopathy? Outlined in this table below, the population is active men, intervention is having limited ankle dorsiflexion, compare is those with normal ankle range of motion, and outcome is Achilles tendinopathy. When tendons of the gastrocnemius and the soleus muscles react poorly to overuse and has decreased healing, Achilles tendinopathy occurs. This means Achilles tendinopathy is a non-inflammatory degenerative disorder. Degeneration can be due to repetition or increased loading of the tendon, resulting in a loss of normal collagen patterns, which leads to disorganization of collagen and proliferative extracellular matrix. Over time, increased participation in both competitive and recreational sporting activities has led a rise in the incidence of Achilles tendinopathy. Like most musculoskeletal pathologies, Achilles tendinopathy injuries are not strictly confined to a particular sport or physical active person. They can, however, be more common in those athletes who participate in tennis, volleyball, soccer, and track and field events. Despite this, studies have shown that in a group of 58 patients who were suffering from Achilles tendinopathy injury, nearly one-third of the group did not participate in any vigorous sport physical activities. Restricted dorsiflexion at the ankle joint is a major risk factor that increases the opportunity for the development of Achilles tendon injury to arise. Restricted dorsiflexion can increase the forces applied to the Achilles tendon. Although the Achilles tendon is the strongest tendinous structure in the body and can hold up to 8 times the amount of one's body weight, it accounts for about 50% of all sport-related injuries, according to Freeman, Jordan, and Solskley 2014. Ground reaction force are distributed and absorbed by surrounding structures in order to avoid injury. Injury occurs in cases where excessive peak forces are being unevenly or excessively applied to the tendon. Dorsiflexion helps facilitate ground clearance and prepare the foot for impact, and restricted dorsiflexion will therefore affect the kinematics and temporal patterns of loading forces which act on the lower extremity during normal weight-bearing activities. So, due to the nature of both these studies being prospective cohort studies, they have been identified as level 2 based studies on the NHMRC evidence hierarchy. This level is outlined as a study of test accuracy with comparison to valid reference standards. In the study, limited ankle dorsiflexion increased the risk of mid-portion Achilles tendinopathy in infant recruits, a prospect cohort study, Rabin et al. 2014. The aim of the study is to further explore the role of the ankle dorsiflexion range of motion as measured with the knee bent and that of lower extremity movement pattern as risk factors for mid-portion Achilles tendinopathy with military recruits. With defined outlines of the criteria for inclusion and exclusion, as well as protocols to limit error, the method is conducted in a way in which to be limited bias. However, several limitations were outlined. In the case of the effects of foot structures and range of motion on musculoskeletal overuse injuries, Kaufman and others, 1999, the aim of the study is to determine whether an association exists between foot structure and the development of musculoskeletal overuse injuries with Navy SEAL recruits. Although this study does sit outside the 5-year gap of recently published documents, it does have a strong influence on the future studies conducted, as it outlines that this study is the first to use both the previous studies anatomic measurements and more precise biomechanical methods to quantify the structural characteristics of the foot. Without well-defined outlines of the criteria for inclusion and exclusion, as well as lack of information to explain how this study was conducted in a way in which there is no limit to bias, no significant limitations were outlined either. However, as explained, further research needs to be done to develop strategies, particularly footwear modification, to prevent lower extremity overuse injuries. In Rabin and others' prospective cohort study, the results show that out of the 70 participants, 5 participants were diagnosed with Achilles tendinopathy. These 5 participants showed more than limited ankle dorsiflexion, which was measured non-weight bearing with their knee flexed as shown in Figure 3. The results also concluded that non-weight bearing limited ankle dorsiflexion strongly predicted Achilles tendinopathy. Rabin and others results also suggest that every increase of 1 degree of non-weight bearing ankle dorsiflexion, the chances of developing Achilles tendinopathy were reduced by 0.23, with the best cut-off point being anything above 22 degrees range of motion. The unit odds ratio for this prediction was 0.77, which suggests a relatively high correlation between Achilles tendinopathy and reduced ankle dorsiflexion. However, due to having so few participants with Achilles tendinopathy, the results may not be very accurate at determining the risk of Achilles tendinopathy of active men outside of the study. The relevance to our chosen risk factor is high, however, it has a narrow focus and does not consider other possibilities predicting risk of Achilles tendinopathy. In Kaufman and other studies, they studied the relation between anatomical and biomechanical characteristics and how they relate to lower extremity overuse injury. Of the 449 participants, 33.2% experienced overuse injuries, with 5.1% reporting to have Achilles tendinitis. Kaufman reported that the difference between measurements taken of ankle dorsiflexion with a flexed knee and with an extended knee and how they correspond with incidence of Achilles tendinopathy. The most predominant group of active men who were more susceptible to develop Achilles tendinopathy was shown to be those with a reduced ankle dorsiflexion of below 11.5 degrees, measured when the knee was extended. 7.9% of the group developed Achilles tendinopathy. The next two groups with an increased risk of Achilles tendinopathy were shown to be those with more flexible ankle joints, which were classified above 15 degrees with knee extended and above 23 degrees with knee flexed. Around 5.7 to 5.8 of participants within these groups developed Achilles tendinopathy. The results predicted by Kaufman and others has some focus on our risk factors of restricted ankle joint dorsiflexion, but also considered a possible risk factor of having more flexibility through ankle joint dorsiflexion. However, the study has wide scope and considered other anatomical and biomechanical characteristics and explored their relationship with other overuse injuries. So that apply. The studies evaluated were found to have the highest level of classification in the application of our PICO question. Do active men with limited ankle dorsiflexion have an increased risk of developing Achilles tendinopathy when compared to those with normal range of ankle joint motion? Both studies followed the prospective cohort design and found evidence to support a link between limited dorsiflexion and the development of Achilles tendinopathy. We would definitely include the measurement. However, we would like for other possible risk factors that are also supported by high quality source of information. An example of this is in Kaufman and other studies, which also noted the relationship between Achilles tendinopathy and people with rear foot inversion. References, and thank you for your time.